Hi, everyone. Welcome to another Shop Talk. Today we have Dr. Mark Shepard, and he'll be talking about his recent paper called The Influence of Manual Therapy Dosing on Outcomes with Patients with Hip OA, a Systematic Review. This paper was published in 2022 in JMMT. Mark, thanks for being with us. And can you tell us a little bit about yourself? Give us your background as a manual therapist and your background as a researcher.
Yeah, and thanks for having me, Chad. I currently serve as the program director for Bellin College's Orthopedic Manual Physical Therapy program, their fellowship program. I've been lucky to have Julie Whitman kind of work me into that position as she has stepped aside to focus on family for a little bit. But I've been doing that for the past 3-4 years at this point. Time flies. It's such a great position. I get to work with such great clinicians, and part of that is just hearing some of the things that they struggle with and things that they think about, which kind of gets my mind going a lot when it comes to, oh, that would be a really good research question. But I do that as my full-time job. I live outside of Baltimore, Maryland. I practice clinically on kind of a per diem basis at this point. So I still try to keep my feet in the clinical trenches because I feel like that's probably one of the most humbling places. As you teach, you can get really kind of full of yourself at times. And I just feel like there's nothing better than having a patient telling you that they're not getting better to keep you grounded. So my background in training, I've gone through a orthopedic residency program. I went through fellowship training myself as well through at the time it was Evidence and Motions program, but now it's the Bellin College program. That really kind of got me set in how I practice clinically. Research, I'm really not, well versed in a ton of research, but it's always been something, that's been so important for me. Evidence-based practice has kind of been the name of the game since I was in PT school, which I went to Sacred Heart University, and just a great team of educators up there that just made it, ingrained in my mind when I got out that, I shouldn't just be doing things because of, it's my favorite day of the week that I'm going to be doing something. It should be really based on, the triad of looking at the person, looking at your experience, and then looking at the literature. And so, I've always been into research and using it and wanting to contribute to that. So in 2021, December of last year, I finished up the Doctorate of Science program at Bellin College. And part of that program is that you produce two types of research projects. So systematic review is one of those, which we'll be talking about now. And the other one is a research study. And we're not really doing a ton of randomized controlled trials, but we're doing a lot of cohort trials. And we did a trial looking at sleep and spine pain, which is kind of my interest now, is looking at some of the lifestyle behaviors that are involved in people with persistent pain. My kind of niche is in sleep. But I look at pretty much, doing research and looking at manual therapy. How can we take manual therapy forward and progress it as it's done over the years? So that's kind of my story at this point.
That's a great story. And let me ask, with respect to the current study where you looked at dosage for hip OA, was that more born out of your clinical experience? Was it born out of the fellowship experience, or was that more of a burning research question?
Yeah, I would say it's a little bit of both. I think what we found when we were looking at a lot of the decisions on what we would do, some of it came from Jody Young and Dan Roan from the DSC program, and then some of it came from the other clinicians in the group who were going through the DSC program, Josh Shumway and Bob Salvatore, who were our two co-authors that worked on this. And Jody has some good experience looking at exercise dosage and doing some systematic reviews on that for the lower quarter. Dan, as you know, Chad, Dan's just an idea guy. And, Dan has a nice vantage point because he's heavily involved in a lot of research projects. He's also involved with AOMT and just kind of has a nice pulse on where things are going. So we were all, Josh, myself, and Bob were really dialed in on saying like, hey, we know that this appears to be helpful in the clinical trenches. We utilize this, but we're not really sure like what should we be doing when it comes to specific dosing parameters. And so when we kind of got it all together, Jody and Dan really helped us refine what we would be doing and selecting this topic, so to speak. So it was kind of a blend of everybody on a team base, but Dan kind of guided us towards one direction, and Jody helped us with understanding like how do we look at something like dosage, which has all these parameters that can be reported and that are unfortunately not reported very well in the research as we found.
So what you found, and I'm going to ask you to explain it, you looked at two things, I think. You looked at dosage to outcomes and dosage to effect sizes. Do you mind just summarizing what your paper found?
Yeah, so we had two aims for our review, and I think the first main one was looking at specific dosage parameters of manual therapy related to outcomes such as pain, disability, quality of life outcomes in patients with hip OA. And then second, we really were hoping to try to provide recommendations of optimal manual therapy dosing parameters. So to do this, as a systematic review, we decided to use the PRISMA guidelines, and we screened over 4,500 studies originally, out of which 33 were eligible for full review. From those 33, we whittled it down to 10 of those that made the final cut with just over 760 participants. I think 768 was our final, count on total participants when you put all the studies together. Now, while we were not able to determine optimal dosage parameters, we did observe some trends in our review, and I should caution the listener to say that they're trends. They're not things that I would say, hey, this is hard, fast, cause effect type of relationship. It's far from that. But what we found was large within group effects for pain, range of motion, and self-reported and functional outcomes, specifically when using a long axis thrust technique, specifically when you're performing several of those. One study actually used up to 9 bouts of it. So it's not just a, tug on it and you're done. And clinically, this is what I've kind of found to make sense, when I've utilized it myself, is, using a long axis thrust. If you kind of give it a couple of, those quick impulses there, it seems to kind of relax the area, provide some nice input into the nervous system to make some changes, specifically like with range of motion and pain. Now, some of the other things we found as far as some trends that came out is that longer bouts of non-thrust long axis distraction for 3 to 6 sets, ranging from 30 to 45 seconds, using high force input. And high force input, when you looked at the two studies that we're comparing this, was roughly 16 pounds of force. However much you can kind of figure that out, that's what they graded that out as, I think in newtons. And then if you do that for 10 minutes, kind of out of totality there were large within group changes in pain and range of motion. And I think one other aspect we found was looking at mobilization with movement, specifically into hip flexion and internal rotation. We found both large within group and between group effect sizes for changes in range of motion and pain. So, we did find some helpful trends, I think, that I think clinically kind of makes sense. But there was also some things I was a little bit shocked about, in the sense of like, oh, I was expecting to see more between group changes when you look at the studies together, which we did not find.
Interesting. So, and I know that some of the studies ranged from follow-ups of like 1 day to a full year. And it seemed to me that they were very heterogeneous, that a lot of different types of studies. I mean, what was your take? Were you surprised at the variability and how people dosed in those studies?
Yeah, I mean, there were really very little consistency of parameters, and that was actually a challenge of our studies. We had to actually exclude some studies that I felt were well done studies because they didn't give the depth of parameter descriptions that we were looking for. They may have said, oh, we did, long axis distraction thrust, and that was it. It never said how long, what percentage of sessions those were used forward. And so it was really kind of depressing at times, because I was like, oh, this would be a great one to really look in and sink our teeth into a little bit more, but we just could not. We were pretty specific about what we were looking for. So those 10 studies had at least the minimum amount that we were looking for to try to extrapolate. But even when you have that, there really was no consistency in what was done. I do think the one thing we found most probably prevalent across studies as far as manual therapy, and you can see this when you look at our tables 2 and 3 of the study, is that long axis techniques were probably the most common that popped up, but even still, they were not, consistent across most studies. And even then, long axis distraction was either done through thrust mobilization or non-thrust. So even then, we weren't seeing a commonality of everybody's doing thrust, everybody's using non-thrust, and the dosage of those, like I said, up to 9 bouts, or just doing it 1 or 2 times. So it's challenging, and I think, Chad, you can agree with this, because of your experience and knowledge of the literature. It's just I really don't know if we have a good way of kind of standardizing what we report in the literature. I mean, there's a lot more I'm seeing coming out for this is what we should report for exercise, this, and this. But in manual therapy, we have the work from the academy that really helped us understand how to use terminology for manual therapy based off of force direction, positioning, that type of thing. But we're really not seeing that consistently reported across the literature, at least in our time frame. And we look from the year 2000 to pretty much the end of 2021. And so, I think going forward, from a research standpoint, we really need to kind of say, look, these are the things at a minimum that we should be reporting. Not that it has to be written about in the methods section in great detail, but you should have at least a table or appendix or something that somebody can go to and say, this is exactly what was done. And then furthermore, having a protocol assessment saying that it was what we said we would do was actually performed in that study. So that's what I would love to see to really get a little bit more of the detail that we need in trying to pull this out. Because as a clinician, if I'm reading a trial that says that this, and this is, helping me clinic or, it's receive these particular outcomes that are positive, I want to be able to take that and use that in the clinic. And if I can only say that, oh, long axis distraction thrust technique was done, all right, but there's so much that goes into that, do I do it this way? Do I do it that way? Am I putting it in an open pack versus closed pack position? How is that done? Is important. And of course, depending on the study, some studies are more pragmatic where they say, hey, Chad, go for it. This is what we're doing. You pick it for each patient you're doing, versus, having more control or tight internal validity where you're saying, look, Chad, you're only going to be doing a thrust technique. You're going to do 3 for every person that you get allocated to your manual therapy group. So there's that balance too between, being more pragmatic versus being tightly controlled in our study design. So there's a lot of variables to, I think, trying to get consistency, but it is a challenge. And I hope that going forward, we can come together and say, let's just call out what we need when it comes to dosing parameters that we would like to see reported.
Well, that's a really good point. And having been involved with some recent studies with psychologists, they're very specific about dosing parameters because they're so concerned that, their approach is, it's basically if the fidelity is poor in that approach, the approach isn't going to be therapeutic. Yeah. So, a 1 bout of manual therapy to me isn't necessarily what we do in clinical practice and does not have fidelity. Yeah. So I'm with you on that. That is, I think it needs to be a balance between prescriptive and pragmatic because each patient is different, but there has to be boundaries in what we know as therapeutic. That's why I thought this paper would be such a good one to talk about. And I know you didn't run a meta-analysis because the studies were so different, but did you get any pushback? Have you received any pushback from clinicians or the reviewers during the review process with JMMT?
No, we didn't get much when it came to, pushback from the reviewers. I think the reviewers understood the challenges because when, like I was saying, the consistency was so over the board And so, we said, well, let's look at the data. We'll calculate effect sizes for this, and then try to look at trends and report at least descriptively what we found. So I can't say we've had any pushback from reviewers. If anything, we were denied to some journals because they just weren't interested in publishing on the topic. But it wasn't because of the meta-analysis piece. And I can't say how this was received as much by clinicians or readers, but I will say the coolest thing, and Chad, you probably have experienced this in your career, but it's cool for me, being a newer to the research scene, is I've experienced some clinicians reach out and say, hey, came across your study. We're going to do a journal club with our clinicians. Do you mind if you share some of your results and give us a little bit more that we can talk about? Do you have any things that you would like us to bring up? Or, so that was exactly what Josh, Bob, and I wanted, is for our work to be in the clinical trenches. Because I know for me, you have those articles that, are posted on your desk that, you're just like, you go back to because you find them so meaningful for treating folks. And so that was probably one of the best wins, I think, for publishing, is having someone come to you and say, we're going to discuss what you all came up with. And so that was probably the biggest win for us, but no major pushback right now from what I've seen. But like I said, some journals, both outside the PT world and in the PT world, they're like, we're not interested in publishing this. So which I found interesting.
I was at a journal editor meeting a while back, and the question arose of who's our audience? Is our audience clinicians, or are we writing for other researchers? And I think, and so good on you, you are writing for clinicians, and which should be our audience, I think. And I think a lot of, in many cases, many journals fail to remember that, and they accept those papers that are very research heavy and maybe aren't going to influence clinical practice. I've got a question for you. You report both within group changes and between group changes, and you've already mentioned that there weren't large between group changes, but you did report fairly large effect sizes for within group changes. Do you mind just explaining the difference between those two to the listeners?
Yeah, and I'm glad you brought this up, because it wasn't really probably the main purpose of our review. But I think it's probably one of the most important findings from our work. And again, I think this is because of the clinical aspect and some of the pitfalls of maybe taking the effect sizes without understanding the difference between within group and between group. So within group effect sizes were relatively large for most of our study outcomes. However, the between group effect sizes were varied and were mostly dependent upon that manual therapy type, specifically mobilization with movement, which we found had a large between group effect size. So as you mentioned, within group effect sizes demonstrate the change in outcomes, not the treatment effect or the difference between groups. And change, in my mind, is essentially looking at like your follow-up results minus where you were at baseline. It's kind of like pre-post testing in my mind. So you're looking at kind of the same person within one treatment group, which is not looking at, it's not the same thing as looking at like a treatment effect. So the review, in our review, this is what we were looking at. What was large is that, pre-post change within those folks who got manual therapy. Between group differences requires you to compare data. And usually from what I've seen, that's going to be the outcome mean from two separate groups. You're not just looking at one person in one group within that same group. So, the problem here is that when you look at something like within group effect size or within group changes, you can't conclude that the treatment was truly effective when you want it to compare to something else, because we have, regression to the mean, non-specific effects, natural, abilities for people to get better over time. So that critical distinction here is that the between group effect size, if the study methodology is strong, can account for these types of things. And, I brought this up in the Aon podcast, but Stephen Camper wrote a 2019 Evidence and Practice article on this in JOSPT. And I just think it's a must read because he does such a great job of understanding, the distinction that needs to be made, and then describing like how that plays out in clinical practice. So with those two things in mind, in tying this back to our review, again, we found large within group changes in almost all of our outcomes. So it kind of tells the reader that, if you're using manual therapy in someone with hip OA, you likely will change range of motion, pain, and function. However, due to the varied and small between group effect sizes, manual therapy may not be any more effective than interventions that were compared to in the studies we had, which were exercise, a sham technique, or in this one hurt, ultrasound. So, and if you look at the Bunnell study, which, I remember when that came out, it was kind of a slap in the face because it's a really well done study. And then you look at some of the comparators, and one of those was ultrasound. And so that was something that I think, was a little bit of an eye opener to me, because I was expecting to see a little bit more of those between groups, meaning those changes between the comparator group and the treatment group, which we really didn't see except for mobilization with movement. So clinically, does that mean we throw it out and say it's not beneficial? No, I don't think that. I think what it means is we can't be doing manual therapy for 75% of our treatment session. And I will raise my hand here and say I was doing that at one point. I was using a lot of manual therapy. Granted, that was my bias, and I was going through fellowship training, so I was practicing this stuff in the clinic. But when you put it in comparison to other things, especially exercise really needs to be integrated in, and a large part, as well as education for folks like this, because most people with osteoarthritis have had it for years. So you have those persistent pain changes, the changes in their beliefs behind what's going on, and of course society and this, what we know about OA can play into people's output of pain. So it was interesting to reflect on that. And I remember having conversations with our team and with Dan, and Dan really pointing this out. He's like, this is a really great, piece to kind of highlight in stuff like this, because, a lot of places, and even some of our systematic reviews we were looking at, is that were published ahead of time, didn't really call this out as well. They'd say, oh, there were large changes with manual therapy. However, they were looking more at those within group changes versus between group.
So you raise an excellent point there. And, if you look at, I know you referenced the JOSPT HIP OA guidelines, but if you look at some of the other clinical practice guidelines, they don't recommend manual therapy. And it's probably related to what you just described. And Kim Bunnell's paper is actually very good, but it's also something we consistently see when you compare any interventions to one another. And I agree, most of the CPGs suggest exercise is the way to go with OA. And if we're not doing that, then we're not on par, right? We're not doing the right thing.
Right.
Let me ask you this, and how did this particular paper influence how you manage hip OA, or is it didn't change anything, or did you take anything away from this paper that has altered the way that you train fellows and the way that you treat patients with hip OA?
Yeah, I think this paper in collection with other papers coming out has really changed the way I look at manual therapy, and really patient care in general. To me, there is more coming out pushing us towards what I call person-centered care. Patient-centered care is kind of the term seen in the literature. Nathan Hutting and colleagues wrote a nice piece about this, I believe, last year, about patient-centered care. But I like the term person because patient makes it kind of like a different relationship. Person, if I see that person sitting across as a human being, I kind of see them as just a normal person. I want to help that person out instead of seeing myself as, I'm the clinician and you're the patient. It kind of has that hierarchical um, perception, at least for me. So we kind of term, at least in our fellowship, as this person-centered idea. And this is something that's been kind of evolving over the past year or two for us in our reasoning model. But essentially what we're doing is we're looking at pain mechanisms. So is it nociplastic, nociceptive, neuropathic? We're looking at, what is the condition that that person is potentially presenting with? In this case, maybe hip OA. But what are other things that might be going on, that can contribute to their presentation? Maybe they have some low back pain. Maybe they have knee pain. Maybe they have had, persistent pain that can be contributing to that hip being sensitized. And then finally, what are some of the complicating or influencing factors that play into that person? I'm thinking about psychosocial factors, economic issues, financial issues, and then lifestyle behaviors. And we know with osteoarthritis, looking at diet in particular, those lacking, the adequate amounts of fiber can actually play into, whether one develops symptoms with knee OA. And this is probably more focused in the knee than it is in the hip. But there was a trial by Dye in 2017 that was pulling data from the Massachusetts Framingham study, with that huge sample. And what they found was people who were not ingesting the recommended amount of fiber, daily fiber, were more likely to show persistent pain and symptomatic knee pain, regardless of whether they had, whether they had the knee OA findings on radiographic imaging. And they even controlled for BMI and found, even if you were overweight and were eating enough of that fiber, you were not, and had knee OA on radiographs, you were not symptomatic. So to me, that was just a large wake-up call to say, if we're truly still thinking that manual therapy is only affecting one's ability to get better joint mobility, or we're correcting a positional fault or improving just something at the joint level, we are missing the bigger picture. And I kind of look at it like, we are so quick to cast stones at physicians or other professionals who use imaging and say, oh, we shouldn't be looking at pathoanatomic findings. And here we are in our hypotheses. What do we say when you're mentoring with somebody? All right, what are your top hypotheses? Hip OA, labral tear. What are we doing? We're just doing the same thing that they're doing when they look at their images. We need to be person-centered and think way beyond just this name that's pathoanatomic in nature. So to me, when I look at these findings, it says, manual therapy has a place, but are we, one, looking at the right outcomes? And I think part of that is with persistent pain, you're going to see things like conditioned pain modulation changes. You're going to see regional hyperalgesia. So a lot of these studies didn't look at those things. They didn't look at pain pressure threshold. They didn't look at 2-point discrimination, some of those neurologic changes that happen with persistent pain. They didn't really look at things like psychosocial aspects. There were no pain catastrophizing scale investigations that would be interesting to me. So I think, when you look at this, you'd say, well, how does manual therapy play a role in person-centered care? And again, it just tells me, when I'm training and talking to fellows, look, if you're doing this for, a large portion of your treatment time, you're probably missing some other important aspects. And if you're using a person-centered hypothesis where you're looking at some of the complicating and influencing factors, that will probably yield some pretty significant findings where you need to say, okay, I need to educate this person on pain. I need to educate this person and try to change behaviors related to nutrition or sleep or just physical activity, because we know folks with OA are probably fearful of loading the joint and being active, or just don't know how to be active with the condition they have. So kind of a long-winded answer, but it's been something that I'm finding to be a major shift in our reasoning approach and how we decide to target folks with what I think is precision-based manual therapy, or really just precision-based PT.
No, that's a really good point. I think if you look at a lot of the initiatives, the GLAD initiative, the Joint Health Program here at Duke, they will say exactly what you said. That, you know, it, and where manual therapy fits, it may or may not, but the other pieces are critical pieces. So I've just got a couple more questions for you. We'll get you out of here. What are you most proud of with this paper? As a relatively new researcher, what makes you feel most proud?
Yeah, I think the one thing that comes to mind with this is the team effort that goes into something like this. And you know, systematic review is no joke. It was probably one of the most laborious write-ups and processes that we've gone through as a group. I would say case study was a lot of work too when I worked to publish you know, a case study, but this was kind of a shocker. Just with the amount of work that goes into assessing risk of bias, doing a grade assessment. Like, I was like, oh man, this is a lot of deep thought that you have to do to try to give each study that you have included, you know, the amount of attention that it needs. And so with that, it just required really good communication across our team. It required being dependable with each other, knowing that, hey, can you get this done at this time? You know, part of it was part of our DSC curriculum. So, you know, we needed to get it done. Otherwise, Dan and Jody would be on our backs. But we really just wanted to, you know, get this across to the finish line and be proud of the work we've done. And I couldn't have done it without each and every one of our team members. And, you know, one of the hardest pieces, I think, when writing a review, and we only had 10 studies that we included it, you know, some of my colleagues had hundreds, you know, that they were doing full text reviews on. And you know, when you're trying to aggregate and discuss what you found, it's like there's so much out there that it took our team, between Josh, Bob, and I, probably 3 or 4 times to get the discussion where we really wanted it. And part of it that we had a challenge with was we were just probably regurgitating the results section in our discussion. And it was like, how can we take those results and whittle it down to the most important findings? And then at the end of the day, what can we say for clinicians? What can we say that can make sense for the person who just picks this up and maybe reads the discussion and can help try to guide them in a direction, even though we don't really have strong effect sizes that maybe paint a clearer picture or a more strong message we can send out. But the teamwork piece was key for me.
And that's what research is. And I can absolutely substantiate your comment on how much work a systematic review is. And I'm at a point in my career, I have no tolerance for them anymore. There's so much work. Mark, thanks for being with us and sharing your work and out of your busy schedule. How can people contact you? I know you're on Twitter because I follow you. Do you mind sharing your Twitter handle and anything else?
Yeah, sure. So Twitter is a great place to find me. It's at Shep, SHEPDPT. You can definitely find me there. I'm always looking for people to post comments and ask questions about this study if you wish, or other things. You can find me through my Bellin College email account. So that's MARK Shepherd, SHEPHERD @bellincollege.edu. But we're happy to talk to anybody if you have questions about this work or anything else. But I appreciate the venue here, Chad, and it's always great connecting with you as well. So thank you.
Thanks again, Mark.